Bismillahirrahmanirrahim. So, an 18-year-old woman come to the office due to lower abdominal pain that radiate to her lower back and thighs during menses. The patient had no pain while on oral contraceptive but stopped taking them 5 months ago due to unscheduled breakthrough bleeding. Menstrual period now occur every 30 days with a 5 days of bleeding. The pain and bleeding worse on the second day, requiring the patient to change her pad every 4 hours. She also had nausea and fatigue during the first 2 days of menses. The patient is sexually active with a male partner and uses condom inconsistently. She has no intermenstrual bleeding or pain with intercourse. Vital signs are normal. BMI is 19.5 kg. Pelvic examination revealed a small mobile uterus and no palpable adnexal masses. Which of the following is the most likely diagnosis in this patient? A. Adenomyosis, endometriosis, intermittent ovarian torsion, sorry, D. Pelvic congestion syndrome, E. Primary dysmenorrhea, F. Uterine leiomyoma. So this is an 18-year-old woman come to the office having lower abdominal pain that radiate to her lower back and thighs during menses. The patient had no pain when she is taking oral contraceptive pills. There is a heavy bleeding on second day which is associated with nausea and fatigue. So the diagnosis of this question is primary dysmenorrhea. Diagnosis of this question is primary dysmenorrhea, which is a pain during menstruation. And here the correct option is choice E, primary dysmenorrhea. Why the choice E is the correct one? Because this patient who had resumption of ovulation after discontinuing oral contraceptive use now has increased painful lower abdominal cramping associated with menses, suggestive of primary dysmenorrhea. Excessive prostaglandin production during menses can stimulate uterine contraction and result in lower abdominal pain that can radiate to the back and thighs. The first line treatment for primary dysmenorrhea is NSAID non-steroidal anti-inflammatory drugs which reduce prostaglandin synthesis. Combined oral contraceptive can also be used, although this patient previously had unscheduled breakthrough bleeding as a side effect of combined oral contraceptive. She can be prescribed another formulation that limits this side effect. Come to the incorrect one, adenomyosis. So adenomyosis can cause painful menses. However, this diagnosis is less likely because this patient does not have tender, symmetrically enlarged uterus. Choice B, endometriosis. Endometriosis is a common cause of painful menses. Patient often having additional pain during urination, bowel movements, and sexual activity. Patient with endometriosis have a fixed, immobile uterus or adnexal masses due to the ectopic endometrial gland and stroma. Choice C, intermittent ovarian torsion. So intermittent ovarian torsion can cause lower abdominal pain and nausea. However, patients typically have adnexal masses and symptoms are not confined to the menstrual period. Choice D, pelvic congestion syndrome. So pelvic congestion syndrome typically present as a dull, ill-defined pelvic ache that worsen with intercourse or during long period of standing. Patients with pelvic congestion syndrome have pain prior to menses that is then relieved by menses. Choice F, uterine leiomyoma. So uterine leiomyoma can cause pelvic pain secondary to bulk symptoms. Most patients have heavy prolonged menses and an enlarged irregular uterus.